Sir, please start.
Welcome everyone. On behalf of Maha AP team, I would like to welcome you all for the first subspecialty chapter of Maha AP. At the onset, it is a privilege to introduce our chairman, Maha AP, Dr. Jayashree Sivalkar. She is a developmental pediatrician and a child psychologist. She is a national level life skills trainer. I would like Madam to continue further and give a brief introduction of our IAP President, Dr. Khadkar.
Good evening, everybody. On behalf of Maha IP, I welcome you all for this pediatric subspecialty nephrology narratives today's session. The new team has started working immediate effect, and today we are here with very important topic related with nephrology. And to start the session, to welcome the audience, I invite our Central IP Dynamic President, Dr. Vasant Khadkar. Is he there? Dr. Khadkar is there?
Sanjay sir, can we have the Khadkar sir on line?
Sir is on another meeting. Continue.
Okay.
Okay. So if sir joins, we can invite him for his blessings and words of advice. Sir is always there for all our activities, but we know that he is busy now. So we go ahead with our program. I invite Dr. Sanjay Pakmode sir, President Maha IP, for his blessings and welcome address. Dr. Sanjay Pakmode sir.
Good evening, everyone. Now, this is first month of our academic activities and the last week which is going on. And we thought of the subspecialty series on this last week of last Friday of every month. So in the subspecialty series, we are covering all the specialties, and this time we have covered the nephrology as a subject and titled as the nephrology narratives. We know I welcome all the guests, today's speakers and the presenters, Jyoti Singhal Madam expert, and Praveen Devre sir, Nikita Gupta as a moderator, and Mirgunde sir as a chairperson, and Anjini and Dr. Soham as the presenters. And I also welcome our scientific chairperson, Dr. Minhas sir, and our women's wing chairperson, Dr. Jayashree Sivalkar Madam, and our another scientific person who is helping Dr. Minhas sir, Dr. Manish Tiwari sir, and all the Maha IPians who have joined today's meet. I welcome you all. And this is academic, this is the fourth virtual program of this month. And this program is specially we have dedicated to the nephrology. And I know the pediatric nephrology is really a very important topic. There are n number of diseases which are rising in the pediatric population, and we see the many diseases which can be preventable if we have done justice to the babies, like prescribing the drugs in the beginning, also early detection and the management. So now the pediatric treatment and the research has very much evolved, and we want to know from the experts through presenters that what are the newer things in the pediatric nephrology. And so we have arranged this nephrology narratives. So again, I give the presenters. I think they are both the presenters are from the GMC Nagpur, and best of luck from my side. And I hope I'll not be able to join further because the flight has already started. So I'll not be more. I will be on the airplane mode. So once again, thank you all.
Thank you, Dr. Sanjay Pakmode. I'm sure this initiative is going to help all the pediatricians because every specialty is expanding so much that it is very difficult to keep pace with all specialties. So such sessions are definitely helpful for everybody. Now I invite Dr. Amol Pawar, Secretary Maha IP, for his wishes for today's session. But I cannot see Dr. Amol Pawar. Is he there?
No, ma'am. Amol sir nahi.
Okay, so if he joins, we can ask sir to give his wishes. Now I invite the convener, Maha-IP, Dr. Sanjay Deshmukh, for his wishes and his address.
So, good evening, everybody. I welcome you all for this digital platform. And today is the first subspecialty series on nephrology. I wish all the best to the team, the scientific team, Dr. Minal Sheikh, Dr. Manish Tiwari, Dr. Vaz, Dr. Chate. They are doing the fantastic work. My best wishes to the all presenters and chairpersons. Sorry, we are going for the Maha-AP first CB meeting to Kolhapur. So not able to continue. Our best wishes. Thank you. Thank you very much.
Thank you. Thank you, sir. Choosing the right, correct topics, then inviting, choosing the correct speakers is a very tough job. And it is the scientific chairman Maha-IP, Dr. Mehnaz Sheikh, who has started this with a bang with nephrology narratives. So I invite Dr. Mehnaz Sheikh for his thoughts, to share his thoughts.
Thank you, madam. Good evening. Thank you for the kind word. It's a team efforts. We have a great team under the leadership of Dr. Pakmode, Dr. Amol Pawar, and Dr. Sanjay Deshmukh as a convener. So we would seek good things to come as possible. Thank you from my end. But before I conclude, I invite, I see Dr. Sanjay sir over there, who is a I invite for him to have a small from his side. Dr. Sanjay Joshi is there, Sanjay?
Yeah.
Sorry.
Hello. Hello. Good evening, all. President Maharashtra IP, Dr. Sanjay, Secretary Amol, Scientific Convener Minaj, Jaya ma'am. I wish this activity a great luck. The beginning of the scientific activity is with a bang for Maharashtra IP, and I am pretty sure that for the whole year it will be a great academic feast for all the Maharashtra IPL. All the best to each and every for today's session and each and every session which are forthcoming. Thank you, Minaj. Thank you.
Thank you. Thank you, Dr. Joshi. To take the program forward in a subject like nephrology, it is always great to have a person who herself or himself is an expert in that topic. So we are very fortunate to have Dr. Nikita Gupta, MD and consultant pediatric nephrologist to moderate today's session. She is attached with Kingsway. Can we have a slide, please? Introduction slide of Dr. Nikita.
Pallavi, madam.
So she is attached with Kingsway, Nagpur. She is attached with New Era Mother and Child Hospital. She is a fellow pediatric nephrologist from. She has done fellowship from Vadia. She has done training in pediatric renal transplant, and her interests are critical care nephrology, renal nutrition, and renal transplant. So great to have Dr. Nikita today as a moderator. And I hand over mic to Dr. Nikita to take the proceedings further.
Simba.
Hello, am I audible?
Yes, ma'am. Yes,
Yes.
ma'am. You are audible.
Thank you,
And I
madam,
was-
for the kind introduction. At the outset, I am very much thankful to Maharashtra IIP, Dr. Pakmode sir, Dr. Pawar sir, and Dr. Deshmukh sir for initiating the subspecialty series. And I am very thankful that they have given me opportunity to moderate this session on pediatric nephrology. Now let's begin the session with the introduction of our today's chairperson. Dr. Shishir Mirgunde, sir. Sir is Medical Superintendent at CR Hospital, GMC Kolhapur. Professor and HOD, Neeraj. Welcome, sir. Next, I will be introducing our today's experts who will be guiding us through their knowledge in pediatric nephrology throughout this session. Dr. Jyoti Singhal, madam. She is a consultant pediatric nephrologist at KM Hospital, Pune. Madam had been West Zone representative of Indian Society of Pediatric Nephrology 2021-23 and convener of nephrology chapter of IIP Pune branch 21-22. Her areas of interest are acute kidney injury and tubular disorder. Welcome, madam. Our next expert is Dr. Pawan Deure, sir, who is consultant pediatric nephrologist at Nashik. Sir practices at Kids Kidney Clinic, Nashik, and is assistant professor at Vasantrao Pawar Medical College. And his area of interest includes prevention and early detection of kidney problems. Welcome, sir. We have with us the third year junior residents from Department of Pediatrics, GMC Nagpur, Dr. Anjali and Dr. Soham, who will be presenting cases for us. So I welcome you all, and we will be beginning with today's cases, and we have selected the two most important topics from nephrology that we come across in our day-to-day practice. So first, we will be learning about how to evaluate a child with urinary tract infection, and second we will be discussing on approach to child with hematuria. So I would request Dr. Anjani to please start with the case presentation.
Yeah. In the meantime, when Anjali share her PPT, we have our Secretary Maharashtra, our own beloved Dr. Amul Pawar. We welcome you, Dr. Amul Pawar, our Secretary General
Thank
Maharashtra,
you.
and invite your comments, please.
Thank you, Minaj sir. It is very great initiative. Nephrology narratives. Dr. Sanjay Pakmode sir, yourself, then Dr. Sanjay Deshmukh, and everyone coined this term. And almost, I think 51 attendees they are there in this webinar. So I welcome both the presenters, both the experts, and today chairperson Dr. Shishir Mirgunde sir. And hand over back to Dr. Nikita Gupta. Have a happy learning to all of you. Thank you.
Thank you.
Thank you, sir. Now I would request Dr. Anjani to go ahead with the case presentation.
Thank you so much, ma'am, for the opportunity. We'll start with our first case. A 2.5-year-old male child was admitted with complaints of high-grade fever.
Wait a minute. Kindly share your screen, please.
Yes, sir.
Sir, is the screen visible? I've already
Share is visible.
presenting.
Screen is visible.
Screen is visible,
Yeah.
sir.
Yeah, please go ahead. Yeah, go ahead.
Nikita ma'am, kindly go ahead.
Yeah. Hello, Anjani.
Hello.
Okay.
Anjali ma'am,
Yeah. Anjani, you can start.
Yes, ma'am. A 2.5-year-old male child was admitted with complaints of high-grade fever since 3 days, 2 episodes of vomiting, abdominal pain, and reduced oral intake. On inquiring further, mother confirmed discomfort while passage of urine. No history of loose stools, cough, cold, or seizures were noted. No history of any previous admission or prior episode of urinary tract infection. Good urinary stream as per mother. The mother also complained of constipation since 4 to 5 months. She said that the child was passing hard stools and was straining while passage of stools. On antenatal history, he was a full-term, normal vaginally delivered neonate. No history of antenatally detected hydronephrosis or oligohydramnios. Immunization was completed as per schedule. He was a developmentally normal kid. On examination, weight was 12 kilograms, which lied between 10 to 25th centile. Height was 85 centimeters. Recorded temperature was 101 degree Fahrenheit. There were no signs of dehydration. Pulse rate was 130 per minute, regular normovolemic, and all peripheral pulses were well felt. Respiratory rate was 26 per minute regular. Blood pressure was 98 by 64 millimeter mercury. On abdominal examination, the abdomen was soft. No organomegaly was noted. Bilateral loin tenderness was noted. Genitals showed bilaterally distended testes. but phimosis was present. The spine was normal. The child was provisionally diagnosed as a case of urinary tract infection and managed further.
So I would request Dr. Pawan sir to kindly guide that when should we suspect urinary tract infection in a child?
Yes, sir. Good evening, everyone. And I first of all thanks the Maha IP team for giving me this opportunity. So this patient has got the symptoms of UTI, and you should suspect the patients having UTI symptoms according to the age. So a child who is just 2 months old or even less than 6 months old will not have this classical symptoms of dysuria or even crying while micturition. Those are not very classical symptoms of UTI, which will not be seen in these young patients. So a very young infant, even simple fever, irritability, lethargy, poor feeding, you should suspect urinary tract infection and send a proper urine sample. Then when we move to the next age group, any child who is more than 2 months old with hematuria or increased urine frequency or passing cloudy urine, along with above mentioned symptoms, you should suspect UTI. And the one who is more than 2 years old, and if the child is having a good bladder control, then he can tell you symptoms about dysuria or frequency or urgency, or there can be symptoms of incontinence, but only in those children who are bladder trained. And along with that, if there is symptoms of suprapubic pain or urine frequency, those are symptoms of cystitis. And basically, these are the patients in which you should suspect urinary tract infection.
So then comes that after history, the most important thing is to consider that whether the child is just having a ascending urinary tract infection, or are there any underlying predisposing factor that has led to UTI in this child. So I would request Dr. Jyoti madam to guide us on what important points we should be keeping in mind while examining such children. What are those conditions that predisposes to UTI in children?
Yeah, thank you, Nikita, for the question. So, as Pawan has already outlined that the symptoms which we need to consider when we are suspecting UTI. So, at the same time, while we are waiting for the results, it's important to examine any child, whatever the cause of the fever might be. So, when you're strongly suspecting UTI, we need to concentrate on a per abdominal examination, the neurological examination, especially of the lower limbs, the spine, and the external genitals. So abdomen, we are trying to look for the signs of pyelonephritis as it was present in this child, which was loin tenderness, which gives us the indication that the child might be having pyelonephritis. The presence of fecolates and palpable bladder basically gives us indication that the child might have a underlying condition of obstructive uropathy, and fecolates suggest the presence of bladder bowel dysfunction. Spine examination is a very important part where you're looking for underlying spinal abnormality. So we have outward signs in the form of sacral dimple, tuft of hair, or lipoma, and then neurological evaluation of the lower limbs where you check for the reflexes, if the reflexes are brisk. Also, it is very important, which is not mentioned in this slide, is always look for the buttocks inequality. Sometimes the gluteal folds inequality in itself can suggest that the child might have an underlying spinal abnormality. So looking at the spine after removing the clothes is very important. Then looking at external genitals in girls, labial adhesions, we have been coming across it quite often, and that in itself can predispose to infection. In boys, presence of phimosis, hypospadias, per se might not be responsible for UTI, but should be looked for because taking care of these anatomical condition will prevent the recurrence of the UTI further if there is underlying congenital abnormality also. So per se, phimosis and hypospadias should not be labeled as a cause of UTI or as an underlying abnormality. These are just the additional abnormality which might be present in these children who have congenital abnormality of kidneys and urinary tract. And further, coming to your second question, Nikita, about the predisposing factors for UTI. So we are basically looking for conditions which are leading to obstructive uropathy, which could be posterior urethral valves in a boy, or functional obstruction in the form of bladder bowel dysfunction, or if there is obstructive uropathy in the form of stones. And secondly, the most common in 25% of children with recurrent UTI, you might get presence of vesico-ureteric reflux. So that is what we are trying to figure out when any child has a urinary tract infection.
Thank you, ma'am. So now let us proceed with investigation of the child.
The investigations revealed a total leukocyte count of 14,000 with 74% neutrophils. CRP was raised with 42 milligram per deciliter. A renal function test was normal with blood urea of 30 milligram per deciliter and serum creatinine was 0.4 milligram per deciliter. A urine routine microscopy revealed a clear, pale yellow-colored urine with a pH of 6.5. Albumin, sugar, ketones were negative. Pus cells were 30 to 40 per high power field. 1 to 2 epithelial cells and 5 to 6 RBCs were noted per high power field. Casts and crystals were absent, and bacteria was 2+. IV antibiotics were started while awaiting for urine culture.
Okay. So urine routine of this child, it showed 30 to 40 pus cells. So now comes the important question. I would like Dr. Pawan sir to please elaborate on how should we interpret the urine routine report, and are there any other bedside tests which are available to screen a child having UTI?
Yes. So it is a very mandatory to send a urine sample, and you should know how to interpret. So basically, either the urine could have been processed as uncentrifuged sample or it could be a centrifuge sample. So most of the time, the laboratories, they centrifuge that urine in 3000 rotations per minute in the centrifuge machine, and then they examine the sediments, and if that is showing more than 5 pus cells per high power field, it is suggestive of leukocyturia. And just presence of leukocytes or the pus cells without any symptoms in any child doesn't suggest that it is UTI. So there should be a symptomatic child, and along with that there should be significant pus cells which should be present in the urine. And along with that, what I would suggest is that you should always carry a urine dipstick kit with you, because nowadays this multi-sticks, we called it multi-sticks, which are available in the pharmacy, and in that the important one is leukocyte esterase and nitrite test. So if leukocyte esterase and nitrite both are negative, it has got a very good negative predictive value, and if both are positive, then it has got a good chance that you can label this, you can call this as urinary tract infection, because it has got a 75 to 80% positive predictive value also if both are positive. But the definition of UTI, you should be able to see the pus cells if you want to define a UTI. But yes, for the bedside testing, this is good enough.
Okay. So now comes the most crucial part of UTI, that is the urine culture. So it is the confirmatory test for the presence of UTI. So I would like Madam to please guide us to how to ideally collect the sample for the urine culture and how to interpret the culture report.
So urine culture being the diagnostic test for UTI, it is very important for the correct method of culture, because if it's not corrected in correct method, then it might just suggest contamination and the child can be wrongly labeled as UTI when actually the cause of fever might be something else. So first and foremost, which we often come across, is this back collection. We can understand that collecting urine in an infant or a younger child becomes difficult, like a clean cat sample, and it requires patience on the part of parents, or as of sometimes doctors also, because they are in a hurry to start antibiotics and they might feel that we need to send a culture. But keeping that in mind, that collecting a urine by a Euro bag leads to 30 to 80% chance of contamination, and it is not going to lead us to diagnosing UTI. So collecting urine in a proper method is very important. So it can be collected either by a clean catch method. So in infants, what can be done is certain stimulation methods where you kind of feed the baby first. You ask the mother to feed the baby so that the urine is collected in the bladder. And then the bladder is stimulated either by spraying a cold water on the suprapubic region, or you just apply a gauze with a AHD or a sterilium, which is kind of a cold thing, and then that just stimulates the bladder, and then the child will pass the urine. Or the fastest method will be collecting a urine by just going in and out with an infant feeding tube and collecting the sample. Or Suprapubic aspiration is also one of the methods, but it is advisable to be done by person who is experienced in it, though it is very simple and it can be in fact done by using bedside sonography where you just see the bladder and then put the needle inside. So given a choice, I would say that collect a clean cat sample and or just catheterized sample. And when the urine is collected, it is very important that it is sent as soon as possible to the lab within 1 to 2 hours. And if there is any delay of some sort, let's say the child has come in the evening and the labs are closed, so the urine can be kept for 4 hours with refrigeration and then sent to the lab. Then interpreting the urine culture is also very important. If it is clearly defined that it should be a significant growth of a single pathogenic bacteria. If there are multiple bacteria which are seen on the culture, that clearly states that it might be a contamination. And significant growth is defined by different collection method. So in suprapubic aspiration, if the growth is more than 10 to the power 3, or by catheterization, if it's more than 10 to the power 4, and by clean cat sample, if it is between 10 raised to the power 4 to 5, is defined as significant growth. And if there is no significant bacterial growth, leukocyturia should not be considered as diagnostic of UTI.
Okay, noted, madam. So the
In our
urine culture and sense.
In our given case scenario, the urine culture and sensitivity report showed growth of E. coli more than 10 to the power 5 colony-forming units per ml, sensitive to several antibiotics like amoxiclav and ciprofloxacin, and resistant to a few handful of antibiotics.
So now we move ahead and let's see the management of the child with UTI. So broadly, it can be divided into two categories. So I would like to request Pawan sir to please guide us on the acute management of a child presenting with UTI, and madam to guide us on how to evaluate the risk factors for the recurrence of UTI in child.
So basically, the treatment should be started promptly if there is a febrile UTI patient. If it is a patient who is having cystitis, that means only urine urgency or frequency or just dysuria, this is what we call a lower UTI, then you can decide, you can give treatment as oral antibiotic for this patient on an outpatient basis. But if the child is sick, and especially if the child is less than 2 months old, has got all signs of sepsis, poor oral intake, lethargic, and that is the case where you should promptly start IV antibiotic. IV antibiotic is to be given till the patient shows a clinical response and till you get a culture report, and after that you can decide if there is anything oral antibiotic is available depending on the culture report, and then you can shift the patient to oral antibiotic. Along with that, supportive care is very important. You should hydrate the patient very well. Use antipyretic which are non-nephrotoxic, and total antibiotic duration, oral plus IV, can be up to 10 days or 14 days, depending if it is acute pyelonephritis or it is just a basically febrile UTI without pyelonephritis. And after that, along with that, you should also do ultrasound whenever the patient is hospitalized. Never postpone it that we'll do it after the patient has gone home. Do it when the patient is there in front of you. That we'll discuss further. So over to you.
Coming to evaluation of any child who presents with UTI. So as Dr. Pawan already outlined, that ultrasonography is something which is needed for each and every patient in whom you have diagnosed a urinary tract infection. While we have advised sonography, it is also very important to assess for bladder bowel dysfunction. Many a time, straightforward questions asking the patients that whether the child has constipation, the first answer you'll get from majority of parents will be, no, my child does not have constipation. So it is very important. You can just ask them if the child is hospitalized to just document, or if the child is being treated on the OPD basis, to just ask them to keep a record and present them to you when they come to the OPD for the follow-up. And many a times just doing this, we realize that actually the child has constipation. And in fact, in older children, the parents also do realize that the child actually has constipation, which might be actually suggestive of bladder bowel dysfunction. So that is one thing. After the ultrasonography is done, and if the ultrasonography shows any abnormality, which we'll be discussing further, what does these abnormalities actually mean? So if the ultrasonography is abnormal, we go ahead in doing micturating cystourethropography, or as it is called MCU or BCUG at different places. But if there is only one UTI and the ultrasonography is normal and there is no bladder ball dysfunction, we just need to keep this patients on follow-up. In another case scenario, if you have a young child less than 2 years of age and the UTI which this child has is a non-E. coli UTI, and in cases of recurrent UTI, we need to strongly suspect other abnormalities irrespective of the findings on ultrasonography. So many a times we do come across ultrasonography which just shows mild PCS dilatation, but the MCU reveals that actually the child has high-grade VUR. So if the child has recurrent UTI and in a younger child with non-E. coli UTI, MCU is warranted. And if the MCU shows high-grade VUR in a child with recurrent UTI, then we go ahead with DMSA. This is to demonstrate scarring, and we'll discuss about it also in detail further.
In our child, the ultrasonography findings revealed bilaterally mildly bulky kidneys with increased cortical echogenicity. The corticomedullary differentiation was maintained. No obvious calculi or hydronephrosis was noted. The bladder was partially distended with thickened walls and mobile internal echos. Mild ascites was present. The impression was of cystitis with suspected pyelonephritis.
So, sir, I would like to ask you that your comments regarding the sonography report of this child, and what are the details that we should be looking for while examining the ultrasound of child with suspected UTI.
So ultrasound is a very important investigation, and quite a few sonologists, they will just write that the kidneys are normal in size and the bladder is normal or bladder is thickened. So it is not a proper report. And many times the report mentions that the bladder is thickened, it is suggestive of cystitis. So on ultrasound, you cannot diagnose cystitis, first thing. And second, if you're sending for an ultrasound, I usually write everything on paper that I want a sizes of the kidney along with the echo texture and CMDs to be mentioned, and size as in centimeter, not that just normal size or bulky kidneys. There should be a proper numericals should be written there. Second thing which I always ask for is the pelvis AP diameter. So pelvis AP diameter gives you an idea whether the child is having any mild hydronephrosis or not. Then next thing is ureter dilatation, or you can just write on the paper on the prescription to the sonologist that mention the ureter size and diameter. Then urinary bladder wall thickness. So in that you can ask urinary bladder full volume and the wall thickness in a full bladder. That has to be mentioned, and along with that post-void residue. So post-void residue should not be more than 20 ml in a child who is more than 5 years of age, and should not less than 5 years of age, and anyone who is more than 7 years of age, the post-void residue should not be more than 10 ml. So that is called as, anything more than that is called as significant post-void residue. Along with that, always ask the sonologist to look at the rectum and ask him to comment whether there is any fecal impaction is there, or you can just tell them to mention the transverse rectal diameter to be measured and mentioned on the paper, because that transverse rectal diameter will give you an idea whether the child has got any bowel bladder dysfunction or not. So always be in a discussion, open communication with the sonologist regarding the ultrasound report.
So now, summarizing the case, we have a 2.5-year-old male with first episode of UTI, which is likely pyelonephritis, and the culture is showing E. coli. The history of constipation, chronic constipation is present as a risk factor, and the additional finding of phimosis is present in this child. And the child becomes absolutely normal after receiving 10 days of IV plus oral antibiotic. So we would like to know that does this child need further evaluation, sir?
So like if you want to follow the new guidelines, the UTI guidelines which has come out in 2023. So if it is a non E. coli organism UTI, And if the child is less than less than 2 years of age, that is the indication when you should do MCU. This child is more than 2 years of age. It is an E. coli organism on culture, and you have the cause of UTI in form of constipation, because the constipation is leading to the bowel bladder dysfunction. And along with that, there is a risk factor of phimosis. Additionally, the ultrasound is normal. The third thing which is mentioned in the guidelines along with non-E. coli UTI and the age criteria, the third one is that USG should be abnormal. In this patient, apart from that bulky kidneys, there was no mention of hydronephrosis or hydroureter. So in this case, at present, there is no need of MCU, but yes, the treatment of constipation and the treatment of phimosis is very much important. And always tell them to um, uh, apply lignocaine jelly to retract the prepuce and maintain a good genital hygiene, because this will lead to a second this may lead to a second UTI. So yes, this child probably will not need any further investigation, but a total 10 days of IV plus oral antibiotic is necessary.
So next, we would like to know that what type of patients will require the further evaluation in the form of MCU, and what should be the timing of performing this test. So, madam, please guide us on this.
Yeah, so I think the indications we have already covered, and Dr. Pawan has again reiterated those. So that includes abnormal ultrasound, recurrent UTI, and UTI in a young child with a non-E. coli UTI. So MCU initially there was thinking that we should do it 2 to 3 weeks after the UTI is treated. But right now, once the UTI is treated by antibiotics, it can be done at any time. The important thing to remember is when we have advised MCU, it is important to give antibiotic prophylaxis around the time of MCU. That is, you can start 1 day prior to the scheduled appointment, continue till the day after the MCU. So that kind of takes care of any inadvertent introduction of infection, though it is assumed that the procedure should be done under complete aseptic precautions. But still, we are not yet sure that the child might have an underlying congenital abnormality that in itself is predisposing that child to the urinary tract infection. So it's better that we cover this procedure under antibiotic. And also, I would like to discuss a few bit about MCU in itself. It is always a good practice to see the MCU films yourself and not just look at the printed report. So it is just like looking at an X-ray, which we do quite often, and not look at the X-ray report. In fact, many times we just don't wait for the chest X-ray reporting to be done, but look at it ourselves. Similarly, MCU is a kind of X-ray, and it's better that we kind of get used to interpreting it. So ideal MCU includes 5 films. So first is the scout film. So what does scout film tells us? It gives you information about whether the child's colon is loaded. So as can be seen in this figure, that this is a plain X-ray KUB, and you can see that the colon is quite loaded. So this child could have constipation. It also gives us a chance to look at the spine. So if there is any spinal abnormality like sacral agenesis, that might suggest an underlying spinal abnormality. Then thirdly, if there is any radiodense calculi where the ureters are present, that might in a way give you one of the causes which might be predisposing this child to infection. The second film is the filling phase, where the catheter is introduced into the bladder and the dye is filled according to the bladder capacity of the child. So in this film, what we are supposed to see is whether there is any reflux happening during this filling phase and the bladder wall margin. So children with obstructive uropathy, sometimes you can see those outpouchings in the bladder margin, which suggests that this is a high pressure bladder and the diverticuli are being formed in the bladder. Then we have voiding film, which usually includes a left oblique and a right oblique view, because this gives a correct picture of from where the reflux is happening. So as can be seen in this picture, that we can see clearly a grade 5 reflux which is happening. And also the voiding view gives you the clear picture of the urethra. Especially in boys, we are trying to look at the posterior urethra, which will appear more dilated as compared to the anterior urethra. And lastly, the post-void film, where we are trying to see the presence of post-void residue, which might, if there is no reflux, then the presence of post-void residue might suggest the presence of some obstruction in the urethra. And some amount of post-void residue, of course, will be there if there is reflux, as is seen in this child.
Okay. Please.
So reflux is just in short, it is usually graded from 1 to 5, and grade 3 to 5 are usually high grade, labeled as high grade, and grade 1 and 2 are milder grade. So grade 1 is just when the reflux is in the lower part of the ureter. Grade 2 is it reaches up to the pelvis, but the impression of the pelvis and callicial system are maintained. Grade 3 is there is slight mild to moderate dilatation of the ureter, and you can see the callicial impression, the clubbing keeps on starting. Then grade 4, there is moderate, mild tortuosity of the ureter and dilatation of pelvis. And in grade 5, there is gross dilatation as was seen in the MCU in the previous case. So that was grade 5 UR on the left side. And there is total loss of papillary impression, like you cannot even differentiate the callicial which are being risen from those pelvis cavity.
Okay, thank you, madam. So now knowing about the utility of USG and MCU in evaluating in this child, we would like to know what is the role of DMSA scan in evaluation of this child. So sir, please elaborate on this.
So basically, DMSA scan reveals the only thing which you are worried about any UTI or pyelonephritis is that what is going to happen to that kidney in future. So whether this pyelonephritis is going to leave a scar, and especially the scarring, you are more worried about the scarring is when the patient has a high grade reflux. So you should do a DMSA scan to identify the scarring, and it should not be done immediately. Most of the time I see that this DMSA is done within a month or sometimes within 2 months. So ideally you should wait for at least 4 months before you do a DMSA scan, because the DMSA scan is your treatment is not going to change depending on that scan if you do it early. In fact, an early scan will give you a false positive photopenic area which will be seen. So basically, a photopenic area is area in the scan which doesn't uptake the DMSA. So it could be because of an active infection, or it could be because of scarring. So the DMSA should be done to detect a permanent scarring. This should be especially done in a child who has had an acute pyelonephritis, or if there is any high grade reflux. Especially what is high grade reflux, as Jyoti madam has already said, grade 3, grade 4 and grade 5 VUR are called as high grade reflux, and you should do a DMSA scan especially in this patient. And also there is the risk factors for kidney scarring is if there is delay in starting the IV antibiotic, or if the patient has got recurrent febrile UTI, then yes, this patient has got a risk factor for scarring.
Yeah, thank you, sir. So from this case discussion, we have the take-home messages that urine culture sensitivity is required to diagnose a urinary tract infection. We have to ensure the proper collection of urine for the culture before labeling it as a significant growth. And WBCs in the urine does not always means infection. Single intravenous antibiotic is adequate to treat UTI in indoor setting. And ultrasound scan of urinary tract should be performed after the first episode of UTI in every child. So we have a question in the chat box, sir. I will just take one. Uh, uh, that what is the minimum age for DMSA scan, and what is the indication?
So the indication, like I mentioned, if there is high grade reflux, or if there is recurrent UTI, or if the patient has got any acute pyelonephritis, or even sometimes I say that some very in rare cases there can be a patients with acute pyelonephritis along with the USG or the CT will show that there is abscess in formation. So in that case also you should do a DMSA scan, but also there is no age limit, like at what age you can do. But from the starting of that UTI point, you should wait for at least 4 months. So no minimum age criteria.
Okay. So now moving to our next interesting case and discussion on how to approach a child presenting with hematuria. So I would like to request Dr. Soham to please go ahead with our second case. Dr. Soham?
Dr. Soham, you are not audible. Dr. Soham,
Soham,
are you
unmute.
there? Dr. Soham, are you there? Hello? Dr. Soham? Dr. Nikita, you can take over. Dr. Soham, are you there?
Yeah.
Okay, Dr. Nikita, you can take over.
Okay, sir. We have a 9-year-old male child admitted with complaints of passing red colored urine since 3 to 4 days, swelling over face since 2 to 3 days, and reduced urine output since morning. There is no history of fever, dysuria, rashes over body or joint pain, no history of recent sore throat or skin infection, and no history of vomiting or loose motion. There is no history of similar complaint in past, and no family history of hematuria or any renal disease in family. So now, seeing this case, I would like request Madam to kindly guide that how do we go ahead in a further evaluation of such kind of child who presents with hematuria.
So, any child with hematuria, first thing become that to prove that it's a hematuria, because there are many causes of red color urine. Though this typically the whole syndrome fits into oliguria, edema, and gross hematuria does fit into some a typical triad of glomerulonephritis. But still, if we are talking about any child who presents with a complaint of dark colored urine, it is important to demonstrate that it is hematuria and there are RBCs present in the urine. Because if there are no RBCs, but the heme is present on the urine dipstick, that might suggest the presence of hemoglobinuria or myoglobinuria. So once we have proven that it's a hematuria and there are RBCs present in the urine, the further investigation will depend upon what we are suspecting. So it could be a glomerular cause or a non-glomerular cause. So from history, if it's a dark colored urine like a tea color or a cola color, it usually suggests glomerular cause. And if there is pain associated while passing urine, so it might suggest something like a calculi, so it is non-glomerular. On evaluation, if there is hypertension, some amount of proteinuria on examination, then that suggests that it's a glomerular cause. Though sometimes even lower urinary tract causes of hematuria can, if there is large amount of hematuria, it can give rise to some amount of proteinuria. Though if there is nephrotic range proteinuria, most cases it will be a glomerular cause. The presence of RBC cast, dysmorphic RBCs will be seen in glomerular cause, while crystals, though it is a normal finding in many urine samples which we see, but the presence of certain crystals like uric acid or xanthin crystals, if by chance is reported, suggests a pathological cause of hematuria. So the classical prototype for each of them is acute glomerulonephritis in a glomerular cause and calculi in the non-glomerular cause. So depending upon what initially we have found, the further investigation will go accordingly. So in this child, we have seen that the child has edema, the child has proteinuria, the child has edema, and the child is hypertensive. So most likely it looks like a cause of a glomerular cause of.
Okay. So now on examination, the weight of a child was 22 kg, height was 125 centimeter. It was within 10 to 25th centile. On examination, the child was afebrile, but the blood pressure was more than 95th centile. Facial puffiness was present. Pedal edema was present, and there was no rash or lymphadenopathy. And systemic examination showed no organomegaly. The cardiac examination was normal, and the child was conscious and oriented. The urine visibly was cola colored, and urine output was 0.8 ml per kg per hour. So, at to this point, we have a 9-year-old male child with sudden onset, painless, gross hematuria, edema, oliguria, and hypertension. So what differential should we consider at this point in such case?
So basically, if you are suspecting an acute glomerulonephritis, So in that acute glomerulonephritis, the most common will be any infection-related glomerulonephritis, or another term for that is post-infectious glomerulonephritis. So there will be any history of any infection. Typically, what we know is a streptococcal infection. That's why the term was post-streptococcal glomerulonephritis. But there have been many studies which is showing that any infection can cause precipitate an episode of acute glomerulonephritis. So along with that, there will be a period of latency. So a latent period, and after that there will be an infection. So we call this infection-related glomerulonephritis. And second thing which you should suspect is any immune complex related glomerulonephritis like MPGN or SLE, basically SLE causing lupus nephritis. And the rarer ones are systemic vasculitis like ANCA vasculitis. And along with that, if the patient has got a significant hypertension, or if there is anemia or thrombocytopenia along with these features, then yes, you should suspect hemolytic uremic syndrome. But the most common of these is infection-related glomerulonephritis.
So now moving further with the investigations in this child. So hemoglobin was 11.3. The total count was 9,420 with 58% of neutrophils. Platelet count was normal, which was 2.4 lakh. Peripheral smear showed no cystocyte. CRP was 24, mildly raised. Serum creatinine was 2.6. And blood urea was 118. And the electrolytes were normal. Serum albumin was borderline, that is 3.5 gram percent. And urine routine showed reddish color, 2 plus protein urea, and 20 to 30 pus cells per high power field with more than 100 RBCs, and along with the red cell cast and fine granular cast. The urine protein creatinine ratio was also done, which was 2.4 mg per mg. So, madam, how should we interpret these reports?
Now that we are looking at a prototype of acute glomerulonephritis in this patient, so the urine routine is showing RBCs more than 100, so that confirms the hematuria. So the presence of red cell cast and WBC cast supports, and proteinuria supports that it's a glomerular cause, and we have labeled it as acute glomerulonephritis. Now, when we look at other things, like it could be, when we are looking at AGN, as we said, it could be secondary form, like it could be lupus or HUS. So we need to look at hemogram very closely. Now, in this child, there is no anemia, the platelet count is normal, and the peripheral smear also does not show any other signs. So we can safely say that most likely we are not dealing with that case of acute glomerulonephritis. But being blood urea and serum creatinine being high in this child at presentation kinds of alert me to really closely look at this child after admitting and looking how this child progresses further. Because let's say now this child has oliguria and in a way AKI. So AGN is the cause of AKI. But if this acute kidney injury progresses further, then you are might not be looking at post-infectious glomerulonephritis. But in that case, you might be then shifting your diagnosis to rapidly progressive glomerulonephritis, which might then need biopsy and so on. So closely monitoring this child becomes important when I'm looking at this reports. And also serum potassium, we can see it's slightly on the higher side. So when we are looking at controlling the hypertension in these children, the diuretic will remain the drug of choice for controlling the hypertension. And we will avoid using enalapril because it will, of course, there's an AKI and also potassium is on the higher side. Another thing which alert me to really closely monitor this child is urine protein creatinine ratio being in nephrotic range. Though with acute kidney injury, the urine protein creatinine ratio might be falsely high. So we again need to monitor it further. And serum albumin, again, being on borderline lower side, will need monitoring.
So now on further serological investigation, we found that the C3 of the child was low, that is 20.8. C4 was within normal limit, and ASO titer was very much high, which was 11990, and ANA was negative. Then on ultrasound, the right kidney, the kidney sizes were slightly increased, and parenchymal echogenicity was increased with both the in both the kidneys. CMD was altered in both the kidneys, and there was evidence of mild ascites. with bladder was suboptimally distended with no anechoic contents, and rest of the bladder was normal. And this study shows the feature of medical renal disease with mild ascites. So we would like to know from sir that how does the serum complement assay and sonography help us to proceed further in such cases?
So, C3 complement level gives you an idea whether it is a immune complex mediated problem is going on. So this can be a transient problem because of post-infectious glomerulonephritis, and if the C3 is low, and if the patient is having, like in this patient who is in that atypical age group, more than 8 years of age, then yes, you should also confirm, also do ANA or dsDNA to rule out lupus nephritis, especially if the patient is a female patient. And the C3 complement level gives you an idea whether it is whether this is infection related glomerulonephritis. The USG will tell you if there is increased echogenicity. It will help you to tell that this is some medico-renal disease. But then complement also has to be rechecked again after 6 weeks if you want to see that whether the complement level are coming back to normal or not.
So now, madam, considering the various differential diagnoses for the glomerular hematuria, when should we think beyond the causes beyond PIGN?
At presentation, if there is short latent period or no latent period. So as in, if you are taking a history and the parents say that the child has cough cold and immediately the child's like a URT and immediately child started having gross hematuria, that might suggest the possibility of IgA nephropathy and not post-infectious glomerulonephritis. And as I said, that we need to monitor the creatinine and the urine output after admission. So if there is severe oliguria or rapidly progressive nature of this illness, then we might have to think beyond PIGN. And if the C3 and C4 is normal, again, might suggest something else like vasculitis or IgA nephropathy. An extrarenal manifestation will be seen in condition like lupus nephritis. So this is an early phase. And once you have admitted the child and you are monitoring the child, so as Dr. Pawan pointed out, documenting a C3 level which has normalized, which was low to begin with and has normalized in recovery phase is very important. So it's always mandatory to demonstrate that the C3 level is normal after 8 to 12 weeks of the illness. The proteinuria, if nephrotic range proteinuria persists for beyond 2 to 3 weeks, again, then that becomes a sign or a red flag that the child might have something beyond PIGN, though a low grade of proteinuria might persist for 2 to 3 months. Then gross hematuria again should resolve by 2 to 3 weeks, and microscopic hematuria usually persist in many children for 12 to 18 months. So if only microscopic hematuria is present, then you need not really do anything about it. Hypertension also is usually subsides by 4 to 5 weeks. So when, let's say, if the child is admitted, the RFTs and everything is normal, but many a times you have to discharge these children on antihypertensive. And as they follow up closely in the OPD, you see that you are able to come down on this antihypertensive. So if anything which is going beyond this typical timeline of post-infectious glomerulonephritis, you should suspect some other reason.
Thank you, ma'am. So now we'll know the further course of the child in the ward. So daily weight monitoring and strict intake output charting was done with BP, close BP monitoring. Fluid and salt restriction was done. Hypertension was managed by diuretics and calcium channel blocker was added. Frequent monitoring of the renal functional electrolytes and urine protein was done. And gradually during the course, urine output and renal functions were improved and hypertension was controlled on medication. So likewise, we can see in the chart, the child was admitted almost on 3rd, and by 10th, that is within a week, the creatinine came down from 2.6 to 1.23, and the urea also improved. So the patient was discharged after 10 days on tablet Nicardia and lacilactone at the serum creatinine of 0.8 on discharge, with urine routine showing 1 plus protein urea, which has reduced from previous RBCs of 15 to 20 per high power field, with the urine creatinine ratio of 0.8 and urine protein output was improved to 1.5 ml per kg per hour. After the patient was closely followed up regularly and the antihypertensives were stopped after 6 weeks, serum C3 level was repeated after 12 weeks, which was normal, and hematuria and proteinuria were also resolved in due course. So in this case, although initially the child presented with a few atypical features like the severity of, in terms of severity of the AKI and nephrotic range proteinuria, but he had a typical serology which was suggested post-streptococcal glomerulonephritis, and it followed the expected course of illness as discussed by madam and also the recovery, and therefore needed no further evaluation. So the take-home messages from this case is that it is important to document low C3 in PIGN cases and always look for its normalization after 8 to 12 weeks. Furosemide is a drug of choice for treating the hypertension in children with AGN, and very important to avoid enalapril in acute stage, and it may precipitate the further deterioration of the AKI and hyperkalemia. And monitoring of serum electrolytes, urine output, and blood pressure is very important during admission of the child. So, any questions or any comments? I'm most welcome.
भेज दे मुझे CC हम तीनों को करो.
So with this, we come to end of the discussion, and I would like to thank our chairperson, Dr. Nirgunde sir, and both the experts, Dr. Jyoti Singhal madam and Dr. Pawan Devre sir, for sharing their valuable insights and guiding throughout the case. Thank you so much.
Yeah.
And any
Dr.
questions
Nikita, just a minute.
are most
Yeah,
welcome.
just a minute.
Yes.
Dr. Nikita, now we invite Dr. Shishir sir, who is himself is a good human being and a very good pediatric nephrologist.
Yes.
We have a couple of questions, Nikita. So Nikita, Shishir sir can take up the questions individually with our experts, and then we'll come to the wrap up by the Shishir sir.
Yes.
So take one by one question, Nikita. There are a couple of questions over there.
Yes. So first is, if there are any role of steroid in this case, in the
Which
case of
case?
AGN, in the case of acute glomerulonephritis, I think they are asking that is there any role of short-term steroids?
Yeah, our experts.
So, so in this case, particularly, even it looks very scary. Still, there is no role of steroids, since this was a very classical case of post-infectious glomerulonephritis, or this was actually a post-streptococcal glomerulonephritis. In fact, if you give steroids, it may worsen the hypertension, and the patient may land up in hypertensive encephalopathy. So I would advise you to avoid steroids in such cases. Have patience. With time, like in this patient, with time the creatinine and the blood pressure is going to settle, and no need to panic, even if you know that this is a post-infectious glomerulonephritis.
So another question is regarding UTI, that is to discuss E. coli UTI versus UTI by other organisms.
Well, I invite for this, but I have the same question in my mind. We have the luxury of 3 pediatric nephrologists with us. I invite each of them their comments for this particular question. So starting from Pawan, then Jyoti madam, and then Shishir sir.
So, so the the guidelines clearly mention that it is whether it is E. coli UTI or non-E. coli UTI, and based on that, the further line of management in terms of investigation, it changes. So
Yeah, Pawan.
yeah. So the E. coli is a very common contaminant which can come in the urine culture. So that's why it is not to be given very much importance, and it can be passed away as just one odd UTI. So this is what my first comment will be. Like, over to you, Jyoti madam, if you want to add on anything else.
with you, Pawan. So that's what, when it's a non-E. coli UTI, that most likely kind of gives us a red flag sign that there might be a underlying anatomical abnormality which is predisposing these children to this severe form of UTI. While the E. coli UTI, as Pawan said, it's a common organism which is present in the stools. So one thing is, as it is very important to check the method of collection, because we have had come across many children who have been labeled as UTI just because there is E. coli growth, and otherwise they just had some mild fever, and we go back and ask them how the urine was collected, then they'll say it was by a urobag. So that in itself say that E. coli can be present in, can be, as Pawan said, can be kind of ignored if it's just one of UTI. But if it is a non-E. coli UTI, then we need to kind of think of other abnormality and look for them.
Ishit sir, your comments, because why I'm asking about this question is that we have to impress and make them understand about the E. coli versus non-E. coli UTI and its importance.
Absolutely, absolutely. As Dr. Jyoti said, see, asymptomatic bacteria, that is one thing we should consider. And another thing is we should correlate with the symptomatology and this culture report. If genuinely febrile patient, vomiting, sick looking, along with significant growth, then we should give importance to E. coli also. But definitely mildly symptomatic but non-E. coli, we should give importance. Definitely.
Okay, I have a question for all those our experts and chair. Please elaborate about UTI mimics one by one.
So,
UTI mimics. Pawan first, then Jyoti madam, and then Shishit.
so almost every alternate day, or sometimes, almost every day, a child who is like 4 or 5 year old, he will come with the symptom that this child is passing urine every 5 minutes. हर 5 मिनट में urine pass कर रहा है, हर 5 मिनट में. So this is a very classical symptom of bowel bladder dysfunction causing overactive bladder. So this patient, most of the time I have seen that he has been to 2 or 3 pediatrician. Everyone has given some antibiotics and been labeled as UTI clinically. And in this bowel bladder dysfunction and overactive bladder, the USG has already been done. And what happens is that the bladder capacity decreases because of that constipation. So that thickened bladder is written as cystitis. Like I already mentioned that on USG, if it is mentioned that it is suggestive of cystitis, it is not an urinary tract infection. So this is a very common scenario when the patient is overly diagnosed as UTI, at least given 3 different types of antibiotic for at least a month or so, and simple treatment of constipation is what is required in these patients.
Jyoti madam.
Also comment like similar holds true for, let's say, when a nephrotic patient comes and the urine routine shows protein 4 plus and some pus cells, but then first the nephrotic child is receiving IV antibiotics saying that the child actually has UTI and we need to first rule out UTI. So in this case, I would like to stress that nephrotics can also have some amount of WBCs. So just the presence of leukocytes again does not tell you that the child has UTI. And other features like in AGN cases also you can get WBCs. And I have seen AGN patients also being treated first for UTI and then saying that the child also has UTI and AGN. So presence of WBCs again and again, though we have mentioned it in the take-home messages, does not say that the child has UTI, and we need to kind of confirm it by correct method of urine collection and by culture.
Shishit sir, your take.
See, many times we get WBCs. Many times it is because of febrile conditions. That is one thing. And if it is associated with significant proteinuria, then we have some doubt whether it is glomerular origin or what. Otherwise, correlation with symptomatology is very important, and method of collection of urine. That is, these 2 things should be given more importance while interpreting.
Yeah. Dr. Nikita, there is a question, very interesting question that, and I will little modify that question. I have a child who is around 4 months old, female child, has come with first UTI, diagnosed, treated, and mother is very anxious, and every 2 weeks is come with a report which is positive E. coli, significant, clean cat sample more than 10 to the power 5, child is asymptomatic. So how to proceed for this child? Child is a female child, younger child, 4 months old. And first time, and every time she says, my child is straining while urine and lagvicha manjes vas yete. These two symptoms are there. Otherwise, nothing. So how to proceed this child? Again, Pawan, Jyoti madam, and Shishir sir. And the culture is positive subsequently every 2 weeks. So 3 cultures I have in last 6 weeks.
So first thing is that any infant, I would say, even up to the age of 1.5 years, straining while passing urine can be considered as normal if the child is otherwise active, playful, accepting feeds, growing well, thriving well. Then you should straight away ignore those symptoms. And along with that, the urine sample which was collected first, you should make sure that it was a properly collected sample, which Jyoti madam had earlier mentioned. And if it was like that, then only you should give importance.
Jyoti madam?
I also totally agree with Pawan that many a child, especially in young infants, they when the bladder gets filled, the parents perceive it as if the child, it is just their sensation, bladder full sensation when they are passing urine, like, or it is just before when they pass urine. And if the child is afebrile and nothing else is there, I would not really even send the urine for culture in this scenario.
Exactly. Yeah. Shishir sir.
I'm again and again telling that symptomatology of the child is more important, because just culture positivity or this straining, especially in smaller child, it can be neglected if patient is not at all symptomatic, especially febrile, sick looking, vomiting, like that.
Also, Nikita, you can also opine. We have actually 4
Yeah,
pediatric
Nikita.
nephrologists.
Yeah, Nikita also. Yeah, please. Sorry, my Nikita,
Is it
you also.
okay? So it is the same thing I would also say, and we usually come across such, this is a very common case scenario which you have put forward. And I think, as sir previously mentioned, that in such cases, I think constipation is a very important thing which should be addressed. Because this straining and all those bladder habits can be because of the chronic constipation, which is nowadays very commonly we are seeing, even in the smaller kids, we are seeing a great amount of constipation. So I usually screen those children. As sir mentioned, the transverse rectal diameter, it is a good like a USG screening method where we can just screen that whether the child is actually having constipation or not.
Yeah. One last question from my end with regard to nitrites. What is the timing of sample selection with regard to nitrites? Have, higher nitrite positivity. Anyone can take up.
So, timing of sample, as in when should the urine be collected? If I got your correct question correctly.
Yeah, for especially for nitrite.
So there's no timing. It's like a spot. Whenever the child has passed urine, we can do. So it is said that in infants, usually we won't get nitrites positive because they usually pass very frequently. So there's hardly any time for the urine to be in the bladder and for the organism to convert that into nitrites. But let's say in an infant, if we get nitrites positive, then it's kind of your suspicion will be shifted more towards it being UTI. At the same time, at any time, if we see that the leukocyte esterase and nitrate both are negative, it is highly unlikely that the child has UTI. So it has a very good negative predictive value in terms of that.
So is there a time frame that at least 4 hours of urine should be there to have a nitrite positive and all?
No, it is if the urine in bladder stays for more
Yes.
time, then nitrites will be
Yes,
present.
that's
Why
what.
it is said that in infants, getting nitrite positive is less likely. But not in terms of when we are collecting the urine and then doing the dipstick, then there's no timing of that.
It's the stay of the urine in the bladder.
Yes.
Yeah, Nikita, you can take other questions from the chat box.
Yeah, so there is a question that whether there is need to repeat the culture after the culture positive UTI has been treated. And if the repeat culture comes positive, whether it should be treated or not.
No need to repeat the culture. And if it is positive, again, we have to correlate symptomatology. Patient is clinically better, nothing to do.
Okay, thank you, sir. Then one question regarding AGN, whether there is role of Penidura prophylaxis like it is in rheumatic heart disease. For I think PIGN, this question is pertaining to.
You would like to take this?
Role of Penidura in PSGN.
There is
Jyoti madam, you are muted. Yeah. Pawan, yes, go ahead.
Yeah, so basically this Penidura, in rheumatic heart disease, the PIGN post-streptococcal doesn't leave any permanent damage to the kidney. So there is no role of giving Penidura prophylaxis once these patients are done with their illness. No need to give any prophylaxis after that. But during that acute phase, yes, you have to give some antibiotic, IV or oral.
I would just like to add something.
Yeah, Manisha, please go ahead.
Actually, there is a huge difference between the type of reactions. So Penidura prophylaxis we give in RLT for recurrent. Usually PHGN we don't have recurrence. It is type 3 immune reaction, whereas the RLT is type 2. So usually the immune complexes formation usually doesn't happen in the second or the third episode so frequently. So the chances of recurrence are very less in PHGN. So that's why prophylaxis is not at all indicated in the patients of PSV.
Nikita, any more questions?
And one last question, experience with UTI, antibiotic sensitivity only to colistin. So the drug-resistant UTI, I think this question is regarding.
Anyone? Pawan, Jyoti madam?
Jyoti madam, you can take this question.
So, I'm not sure what exactly the question is, but if in this case scenario, first, usually we start off with antibiotics. If the child has presented with UTI, we send a culture, we meanwhile start the child on antibiotics. And let's say the child has improved, and by that time the urine culture comes and it shows that it is not sensitive to that, only sensitive to colistin, but I would still kind of wait because the child has responded. And if the child has not responded, then I would shift to the drug according to the sensitivity. Though I'm not sure what exactly the question was.
And the question says experience with UTI, antibiotic sensitivity only to colistin. No other.
We
Well,
do get such UTIs where the organism is only sensitive to colistin, and these are usually cases where there is underlying congenital abnormalities like high-grade VUR, and the child has had multiple UTIs in the past. So we do get this such children where we have to ultimately use colistin for treatment of this UTI.
Yes, Dr. Rajesh
Nikita,
I was asking the
I was
question.
coming to that. Rajesh, we have Rajesh with us. He is a professor of pediatric and a very good friend of us, and is an EB member from Maharashtra. So welcome, Rajesh. Then I will invite Dr. Praveen Gokhale sir. He is also EB member from Maharashtra. They are a very good academician, so they can have their opinion and questions as well. Over to you, Rajesh.
Yeah, so we had this child. This was, I think, a year-old child who had recurrent UTI, and every time, either there was Klebsiella or a E. coli. And off late, in the first 3-4 episodes, the cultures, they were sensitive to amoxiclav and ceftriaxone, etc. But last two cultures, it was sensitive only to colistin. And I was wondering, how long can we give colistin? And every time giving colistin, again, it's a nephrotoxic drug. So how do we go about it?
In this scenario, I would say though colistin is a nephrotoxic, but if the organism is not sensitive to any other antibiotic, we don't have a choice than to use this antibiotic. And usually when we do start colistin, we do keep on monitoring the serum creatinine like every 72 hours at least when we have kept these children on colistin. And as I said, it usually the typical case which you have mentioned with a child with recurrent UTI and have been having some underlying congenital abnormality. Usually they present with such organism which become resistant eventually to the other antibiotics. Pavan, do you have any comment or addition to this?
So sometimes I've seen these patients are given oral colistin. So I would suggest that if you have to give colistin in a symptomatic child, better to give it IV. Oral colistin has got no role in these UTI patients.
True. Very true. Yeah, there is a question about drug modification or not drug. I mean, in a dosing of colistin.
Nikita,
you can take this.
Yeah, the last question.
So as long as the renal function remains normal, I think there is no need of renal dose modification, but we need to closely monitor the KFTs while starting the nephrotoxic drug in such children.
Yeah.
Especially when there are certain underlying abnormalities like catheter high risk to renal dysfunction, we should always monitor it.
Manish, any more question? Yeah, if there is no question, we invite Dr. Praveen Gokhale sir to unmute and make some his remarks. Praveen sir? Praveen Gokhale sir? Okay, he's not there. Okay. Over to Manish.
So Dr. Nikita is going to give the vote of thanks.
Okay.
Okay, so with this, we come to an end to a very good discussion, I suppose, on nephrology, and I hope that everybody has learnt, had a good time listening to the nephrology cases. And I would like to thank again the Maharashtra IAP for starting this subspecialty series, and I hope that in further series everybody will get benefit of this. So. I would like to thank our chairperson, Dr. Nirgunde sir, and both of our experts, Dr. Minaj sir, thankful to him, and special thanks to Dr. Manish sir for guiding us throughout and arranging everything. And hope this session was useful for everybody. Thank you so much.
Yeah. Thank you, and thank you to all who are present, including seniors. I could see Dr. Sanjay Joshi, Dr. Chitra Madam, and all. And we continue to do the better in future. A special thanks to presenter Anjani and Soham, their mentor Dr. Manish Tiwari, experts Dr. Pawan Jyoti, Nirgunde sir, and the entire team of the MAHAIP. Thank you. We conclude over here. Good night. We'll see you again in the next session. Good night.
Thank you, sir.
Yeah.
Thank you, sir.